I'd like to move on now to introduce Dela and Kathryn for the next talk. I think it may be Kathryn who's doing the speaking. So Dela is the Executive Director and founder of Gift of Living Donation, or GOLD, which she set up herself, having come forward herself as a living donor for her brother. She and Kathryn will tell us about her many successes in that project. And just this month, she received an honorary doctorate from the London South Bank University for all of her outstanding work. And she's also the author of a book called More Than a Match. We'll hear about the Phone Buddy scheme in her talk. And just to talk about Kathryn Griffiths as well, a renal registrar in South Thames, who sounds like a very busy lady, doing her PhD, and as well as doing clinical work at King's College Hospital, and has been working very closely with GOLD and the London Kidney Network in her QI project with Dela. Thanks so much to both of you for telling us today about your amazing work.
Thank you. Thank you ever so much for inviting us, and it's been a great opportunity to hear all the work that's being done, and why today is especially important, and especially important for our Black kidney patients. So why is today important? If we just look at these two figures and just look at the huge disparity, we can say why today is so important. And those figures of 19 have actually dropped from last year, which was 25. But if we just look at the comparison, that is a huge disparity. And we really have to ask ourselves, well, what are we doing, and what can we do? But I think those figures are also more important, because 50% of the number of people who are on dialysis in London are from the Black community, but we only represent 13% of the population. So an increase in preemptive transplantation would definitely reduce those numbers. And on average as well, and we've been hearing about the impact of dialysis, but the impact on the Black community and on Black patients is huge, because as most of you know, we wait much, much longer for a transplant, and that can be on average 3 to 5 years. So the impact, the emotional, physical impact of spending 3 to 4 years on dialysis is huge. And what we've seen, especially in London, where a lot of our kidney patients may be here alone and they've got family abroad, it can have an extra impact on their mental health. Next slide, please, Kathryn. So what can we do? And we really must, appearing today, we must put patients at the heart of transplantation. That's so key. And we've come to realize that we must also make a change to the renal clinical pathway by introducing a tailored community-based intervention. I mean, if we just consider London itself, our renal population in London, London is one of the most multicultural centers in the world. And a standard recipient pathway really would not deliver health equity. So it's looking at that pathway and what change can we have, and what change can we implement in the pathway. And we've been talking about that, those change ideas. And one of our change ideas is introducing a tailored community-led pathway, intervention in the pathway. And why tailored? Because when you think of community and you think of the Black community, culture, community, connection, conversation play a key role. Patients have the opportunity to talk to somebody from their community who've had lived experience of living donation. It provides Black patients a better understanding of living donation from a cultural perspective. And I think especially when we look at the makeup of our clinicians, most of them are not from the Black communities. So there's a lot of cultural nuances that they may not be able to understand. So culture plays a very, very key role in that. But it also gives Black patients the time and the space to have those honest and frank conversations that sometimes simply cannot just take place within the hospital setting. So we spoke to a lot of Black patients, and what emerged from those conversations was that they found living kidney donation a very, very difficult conversation to have with friends and family. It was a big ask. How do you ask So we've been asking them that, well, actually, maybe there's a different approach to talking about living donation within your family and not having that big ask. But we also spoke with clinicians as well, because we know that there were some barriers they were facing when it came to talking with their Black patients. And especially as we said about those cultural nuances that if you're not from that community, might be very difficult to understand. And a lot of them have said to us that sometimes when they try to discuss living donation and the answer or the feedback is no, it's then very difficult for them to actually continue that conversation of living donation with Black patients. So we looked at the pathway and we knew that there was a gap, and what that gap was, as we said earlier, that community and culture are central to the Black community, then it always makes sense that why are those two elements not included in the healthcare and the renal care when it comes to Black kidney patients. Next slide, please, Kathryn. So that intervention was a fun buddy scheme. That intervention was co-designed by not just us as an organization, but by Black living donors, living donor recipients, clinicians who are from the Black community, and Black patients themselves. So the scheme is based on a referral process, and we sat down with clinicians and said, well, how can we make it easier? We don't want to create any more work for you because we know your workload is very important and it's very heavy at the moment. So we wanted to make sure that the referral process was very, very simple. And also it could actually just kind of seamlessly fit into the existing workforce, into the existing processes, into the existing systems that were already there. But the key thing about the Fear Body scheme is that it's a collaboration. It's a collaboration between the clinicians and the community. And that is so important because without both of us working together, we wouldn't have been able to have the successes that we're going to talk about later. So what we have in the referral system is that we have clinicians, and they're mainly from advanced kidney care, which is really where you've got a lot of those patients that will benefit from the service. And then they referred to GOLD. And then we have that initial assessment. And that referral process, the information we get is very basic, just the name, whether they're pre-transplant, whether they're pre-dialysis, whether they're African, whether they're Caribbean, whether they're male or female. So we just have basic information. We don't have their medical information. We don't have any medical details. And that referral has to be with their consent. But it's during that initial assessment that we're able to match them up with one of our buddies who's actually been one of through the whole process. And then we have a patient follow-up and a clinician follow-up. So that whole process is actually quite simple and it's very, very seamless in terms of working with what's existing. And that's one of the things that we really, really wanted to create. So that is that whole referral process that we've been talking about. I'm now going to hand over to Kathryn and she's going to talk us through the important, which is the data that we've been able to collect.
Thanks so much. It's been a complete privilege to work with someone like Dela, and I think my role really was to try and make this a robust model which we could roll out and sustain. And part of that was we collaborated together to make this structure where you have a core team which has community, transplantation expertise, and then London Kidney Network, which is of course the NHS England funded network. And that core team sort of sets the agenda and the aims, and then other teams pick up different parts of the work. So clinical teams at each site contribute to who they're referring to, contribute referrals, and then the data team, and I think this is a key piece, is that the registrars with data analysis experience collate the data to minimize workload for teams. And that capacity can be found in trainees because we all need to do a QI project. People want to do meaningful things. So it's very much speaking to what we were speaking earlier in terms of KQIP as a whole, but providing a structure to make a meaningful difference for people to feed into works well for trainees. I say as one. The GOLD team obviously was essential. The buddies with lived experience who were trained and DBS certified provide the intervention. So how do we set up what we wanted to measure? So we defined a kind of eligible population. We wanted to say this is a big project, but we actually need to tell people who should you refer. And we came up with the eligibility criteria of an EGFR less than 25, meaning that you're probably going to be near or in AKCC, but you're going to have plenty of time, because a big part of this understanding, and my understanding improved from this, is the need of time for discussions, particularly in this community. It's true for all people, I think, with living donation, but particularly time was important. So you needed to be black or mixed black, less than 70-year-olds with an EGFR less than 25, and no obvious contraindications to transplantation. We then recorded the number of referrals made to GOLD, and if these were pre-dialysis, which is where we tried to implement the pathway, and then if they were referrals from elsewhere, and that includes self-referrals or referrals from dialysis. And that really was to measure implementation. So how well have we managed to implement the scheme? What proportion of the eligible population had we offered referral to? And then the other measure, of course, was the number of referrals who go on to have a potential living donor. And it's important for us to say potential living donor, because that's the threshold at which we wanted to get people to. We wanted to increase conversations to increase potential living donors coming forward. And that takes time, and it's a complex interaction, but actually simply measuring the outcome of transplantation might not capture some of the amazing work this does. For example, if you come forward as a living donor, it doesn't proceed, the work of the QI is still done a lot, because it's enabled that conversation with family, which has sort of relatively immeasurable difference in terms of culture shifts. So that's how we wanted to capture that. And in the interest of time, I'm going to kind of whiz past this, but this is an example of how we're measuring the data. So we're looking at who's eligible in the whole service, pre-RRT and RRT, number of referrals for each of those groups, and then quarterly we're checking the proportion of that group who have a living donor, and the threshold is the living donor comes forward to the living donor coordinator. So there's a renal registrar at each site, which is currently Imperial, King's and Guy's and St Thomas's, and we look through the data and keep it on an NHS share drive between us to keep that per site. So in terms of the impact evaluation, so I'll start this and then hand over back to Dela, but we've embedded the QI project in 3 units across London, as I said, and had a lot of iterative cycles. And there's been 108 referrals and 150 conversations at least about living kidney donation. We've had 11 presenting donors identified by GOLD, and 6 have made contact with living donor coordinators to date. And again, I'd like to say that sort of time lag is really crucial there. We've launched accurate back testing, which means once we've identified people who may be eligible to be offered support by the Peer Buddy scheme, we've been able to devise a text which was sort of co-designed with PPI input, send it out to people who may benefit and allow them to self-refer, which just increased our reach. And there's been a bigger piece of work with anonymized feedback to kind of capture some of that slightly less measurable by numbers experience for patients. Over to you, Dela.
Thank you so much. And we said we've just done a patient questionnaire. And even though the numbers, when we look at the numbers of people who actually took part in the questionnaire, and we sent that out to over 108 patients that they referred, and we were the ones that actually did the questionnaire. It just shows you that, excuse me, that community approach is just so it's just so important. So we developed that questionnaire with Samoye and with the patients as well, and the QI leads. And all of the patients recommended GOLD, and that was all 100% of the patients that said they would recommend GOLD. And there were some free tests, and a lot of the questions we asked, well, why was that the case? And it was always been able that, well, I can speak to somebody from my community. It was that sense of being having that familiar conversation, talking to somebody who they could identify with, and also somebody they could culturally relate to. And I think the key findings for us was that 15 out of the 20 were now able to discuss living donation with friends and family. These were 15 people who never would have thought. And when you look at it, you might think, well, that's quite small. Well, actually, that's 15 people that probably wouldn't have had that conversation with friends and family. But I think the real key change for us that we noticed in the feedback of the questionnaire was that shift in mindset from focusing on dialysis as their first option to living donation. And that for us was huge. A lot of people, first of all, their first focus when we spoke to them on the phone was dialysis. Some of them hadn't even thought of transplantation. So that shift has really empowered them and just given that confidence now to be able to discuss living donation with their friends and family. But not even just in terms of living donation, but their overall kidney care and just taking that sense of ownership. Still, excuse me. And sorry, I do apologize. But not only from the benefits from a patient perspective, but also from a clinical perspective. And this was a quote from one of the renal nurses who referred quite a few of her Black patients. He said the community intervention has had an incredible impact on supporting my Black patients who want to learn more about kidney transplantation. Knowing that I can refer them to God has really enabled me to feel more confident in opening discussions with people who had previously declined transplantation and dialysis. One of the key things about this is, and we always hear within healthcare professionals and the Black community, is that element of trust. And one of the things we've noticed when patients come back to us is that they often say, well, I never knew that my doctor or my nurse or my consultant really cared about me, because there is this perception within the Black community that healthcare professionals do not care. So this has been one really key piece of work that can say, well, actually, they do care. For the fact that you're actually referring your patients to the Peer Body Scheme, it says to them that you do care. Next slide, Kathryn. Over to you, Kathryn. I think you need to take this one.
Yeah, so in the interest of time, I'm going to skip by this. The main point of this slide really was just to show that sort of the measurable and the longer term measurable impact and how we see this QI over time evolving. Some of it was implementation, some of it is living donors coming forward, and then ultimately an increase in preemptive transplantation is the aim. Just a very quick note to challenges. So we tried to structure the QI to release so that the burden of work was not on clinical teams, and that was really essential. So the workforce of the kind of renal registrar was harnessed. Data availability was really difficult. Speaking to the people who were trying to find the data and unite it, and in 3 London sites, it was much more difficult than imagined, with lots of different ways of storing the information, and that was quite something we've kind of raised with LKN in terms of a difficulty in terms of measuring output. We needed to develop robust governance between teams, so we share information in the most minimal and only essential way possible. And as I said, measuring complex change. So in summary, I think we would say more conversations, more potential living donors, more living donor transplants. And over to you for the takeaway minute.
Takeaway. I think the key takeaway I think we would love to get across is that to recognize the significant role community and culture play in transplantation. It's absolutely key. If we're going to increase or boost those numbers, we have to work in collaboration with the community. It's just so important. And we've realized that having those conversations with the phone buddies in the comfort of their home has really just kind of changed their mindset. And we've talked about change, and that's one thing I keep on hearing is about that thinking out of the box. You know, it's looking at that pathway, and we looked at that pathway and we've realized actually that small change that we've had, just including a community-led intervention, is making a huge big difference to Black kidney patients, because it's about those conversations. Without those conversations, there'd be no live donor people coming forward and there'd be no transplants. But I think, again, that's important, is about collaboration partnerships, because it informs, it reforms, and it does transform lives. So we just want to say thank you to all our partnerships in this project, and we look forward to rolling out across London. Thank you so much for listening.
Thanks so much to Dela and Kathryn. I think that's been incredibly inspiring. I think we all want you to come and set up equivalent work in our own towns where we all work. I'm sure you'll have lots of questions later. Please do put them in the chat, everybody. Don't forget about that, and we'll come back to that later. Thanks so much.